Good evening to all our fine viewers. Thanks for being here. My name is George Glazer, and I am a host for this evening's presentation entitled Hypnodontics, Cutting Your Teeth on the Art of Hypnosis in Dentistry. This program is sponsored by the American Society of Clinical Hypnosis Education and Research Foundation. I'm coming to you from Austin, Texas. Our featured speaker is presenting from his home base in Hamilton, Ontario, and Joanna Truitt is in Annapolis, Maryland, serving as our technical producer. This evening, I have the pleasure of introducing a very talented and knowledgeable hypnosis colleague, Dr. Gabor Filo. While his specialty is dentistry, he knows a lot about working with the mind. And don't let anyone tell you there's not a strong connection between your teeth and your mind, because anyone who's had significant dental pain knows it can cause you to lose your mind. Dr. Filo is a diplomate of the American Board of Hypnosis and Dentistry, a life fellow of ASCH, and an honorary member of the Canadian Society of Clinical Hypnosis, Ontario Division, and the Hungarian Association of Hypnosis. He is also a fellow of the Academy of General Dentistry and the Pierre Fauchard Academy. Dr. Filo has been ardently involved with hypnosis and dental hypnosis since 1984, presenting nationally and internationally, both in the hypnosis world and at major North American dental conferences. His expertise is the rapid induction of hypnosis. Currently, he is still in private practice. I think we can safely count on being informed and entertained by Dr. Filo in this webinar. As for some administrative details, please submit your questions using the Q&A button at the bottom of the screen. Joanna and I will monitor the Q&A window, and your questions will be handled by Dr. Filo at several points throughout the presentation. If you need technical assistance, use the chat button and address your request directly to Joanna Truitt. You can also reach her by phone at 443-336-3732 if an issue is not resolved through your chat request. This program offers 2 hours of the ASCH CE credits for membership and certification requirements. The webinar is being recorded for on-demand viewing. And having dispatched with the administrative details, let me turn the screen over to Gabor. Welcome, Gabor.
Thank you, George. And thank you to everybody who's taken time out of the day to come and listen to a hypnodontist. So what's a hypnodontist? Back in about 1958, Aaron Moss, one of the original psychosomatic dentists, coined the term hypnodontia and hypnodontics so that the pejorative associations with hypnosis would be mitigated. With this, he was hoping that both the profession and the laity at large would not be put off by the term hypnosis, since most folks relate to hypnosis based on what they see on TV, on the stage, and other forms of entertainment. Now, what's truly interesting, in 1957, the American Society of Clinical Hypnosis was formed by Milton Erickson. And the first board of directors, if you will, of the association consisted of 7 people, 5 of whom just happened to be dentists, and 1 was from Toronto. So dentistry revivified clinical hypnosis, kept it going, and now we're rarer than those proverbial hen's teeth. I'm hoping to remedy this a little tonight. Now, I know a lot of you folks out in the audience personally. Feel free to heckle and offer your opinions and comments, and that particularly goes to my buddy Ashley. So let's move on then. You heard all this stuff about me. This, I understand, is for the recording. This tells you about stuff. Nobody's got any money involved in this. Now, if you want to get a hold of me, I'm not very creative, so drgfilo@gmail.com and put hypnosis in the subject line, please. And then I'll know that you're referring to the program. Or you can also email ASCH and probably track me down that way. Learning objectives, we're just going to forget for the moment because we're going to cover a tremendous field, which is where this assumption issue comes up. And we all know what assuming does to you. But this will not be about how to do hypnosis from the basics, because we want to talk about, or rather, I want to talk about, and hopefully you'll listen to issues that are rarely talked about, that are germane to dental hypnosis and all other forms of clinical hypnosis as well. So let's charge off and get into the meat of this. For any neophyte dentist, when you get out of dental school and you get to actually work on living bodies, you're happy if you can get them anesthetized, find the tooth, do the filling, and move on. It takes about 5 years before you start creating a practice philosophy. And it can be a very simple practice philosophy. Healthy gums, healthy teeth. This is a philosophy that was espoused by a group practice I was affiliated with for a while. Mine happens to be oral wellness, whole health. Or you can get really involved. And this one I encountered back about 25, 30 years ago. It's called volitional practice. It's trademarked by the group at Cox. Now, for dentists, these are the folks that invented the rear delivery dental system. And they broke it down into 5 possibilities. Urgent care. And these are the people that only come in for emergencies when the pain is bad enough that dying is preferable to seeing the dentist, but we'll see him anyway. So these folks, hypnosis can help a great deal with, but overtly not, it's covert hypnosis. And we'll address this later on. Remedial treatment folks are the ones that want the least amount of time and money. They'll come in, but they don't really want to be there too much. And you'll notice that if you deal with dental folks, as I do predominantly, these describe the dental phobic patient. Those that are in the self-care category work on the premise that if I'm really good, look after my gums, floss daily, get my cavities fixed, then I really don't have to keep showing up as often for hygiene visits as if I didn't. But they're sort of halfway there to being into systems dentistry, where there's a plan, they want the very best possible care, they want to understand it, and they want to be involved. And the last group is the wellness resource. That's where the practice is a general home for these folks that are interested in health, totally involved in their own health care, and expect you to offer insight, advice, care, and information. And for those of us in hypnosis, whether we realize it or not, I think we ultimately evolve to a wellness resource center for our patients because of the nature of what hypnosis is all about. So let's talk about a trance. And trance is more an anthropological term than a science-based term, if you will, from the hard sciences. But I think it's important to understand trances and then realize that there are subsets of trance, which hypnosis just happens to be one of them. Now, trance is defined by Crabtree, and if you want to read both an interesting history of hypnosis and the book that I'm referring to from Adam Crabtree, used to be a priest up here in Toronto back in the 60s and was a psychotherapist at the same time. Did a lot of work with DID patients, multiple personalities in the old parlance. Trance is a state of profound abstraction and absorption. You're so into it that you're oblivious to the rest of it. Now, interestingly enough, Stephen Walensky years ago, and this is his book, and I can recommend that to you as well. Trance states are a crucial part of the fabric of our daily life experience, as well as our symptomology. So what this suggests is that we are daily morphing through different trances, which can be both beneficial and pathological. And as a clinician, it behooves us to be aware of our own issues stemming from an altered state of consciousness, and our patients and our staff, and just generally floating about our daily existence. Now, Michael Murphy, the founder of the Esalen Institute in California, and this is a wonderful book. It's about 800, 1,000 pages, and it's got a great chapter on hypnosis in there. But it covers a lot more than just hypnosis. And what he states, and is very true, is that in those cultures where an altered state of consciousness is valued, they're accepted, they're utilized, and they are considered to be valuable. Then you have the opposite. You have areas in our culture where hypnosis is pejorative, it's affiliated with stage entertainment, and gets bad press, in spite of the fact that it is clinically a phenomenal instrument. So getting back to Adam Crabtree, this book, Trance is Zero, I recommend it again if you want to have a broader understanding of the concept of trance. And he specifies that we morph through 4 different types of trances during the day, possibly in the same hour. And some of them may actually overlap concurrently. So let's take a look at these. The group mind trance, which is rarely recognized, and sadly in today's world, is the root of an awful lot of problems. Each culture, each group has a set of values, perspectives, memes that are continued from generation to generation. And if you're born into North American culture, the world talks to you in a particular way. If you're born into a German one, you're going to be given daily suggestions, myriads of suggestions, with a totally different perspective. And these are hard to break out of. And the larger the group, the more the problem. Now, I thought this was sort of indicative of a cultural trance, a group mind trance, if you will. One old dude saying to the other, back in my day, we walked over and talked. Well, think about the cell phone today, ladies and gentlemen. And as an old curmudgeon, I can tell you that even I'm addicted to it. But sometimes I wish it was the old days. Now, if you've never heard Bruce Lipton, I recommend you give him a shot because he's a phenomenal speaker and presenter. And his award-winning little book, The Biology of Belief, he made a comment about children being in altered states of consciousness till about the age of 5, because if they were fully conscious, nothing would download into their brains. None of that cultural meme would be absorbed. But since they're in an altered state of consciousness, the conscious mind being misdirected to play or do whatever it's doing, all of the cultural memes can be downloaded into kids. And when I started out in hypnosis formally, we were told that children are in trance until proven otherwise. Just call them to dinner if they're on their video games. So relational trance is one where somebody's absorbed in somebody else. And this can be a mere annoyance, downright sociopathic at the other extreme. Interest to obsession, mild to profound. And Lord knows, and I'm sure all of us were in love once, we certainly know what that first blush of neurochemicals floating through our system and how it drives us to be absorbed in one person and one person only. So that's a relational trance. Situational trances are something that's being accomplished in the moment, and you are totally immersed to the exclusion of all else. Now, interestingly enough, Mihai Csikszentmihalyi, who recently passed away, wrote the book Flow. And this could also be his definition of flow, which is the peak experience. And then if you're a dentist, you know exactly what this is. That's an upper first molar being root canal treated. And there's that mid-buccal canal, which is tough to find, tough to instrument, and needs your total undivided attention, to the extent that the world around you doesn't exist while you're working on that canal. And then we have the inner mind trance. That's what we're dealing with. It's totally within us. And one of the definitions, my buddy Ashley Goodman, who's out there somewhere listening, used to talk about in our workshops, was the fact that it's a spiral from the external to the internal, not unlike the diagram. And this is what hypnosis, meditation, and autogenic training, and all these other interesting inner world experiences and technologies are aimed at doing. All of them are a little different, but they all involve leaving the external and dealing with the internal. And this is my understanding of human nature, that we float through these trances, they interact. And the purpose of this diagram was to show you that my grade school education wasn't wasted. I can still do Venn diagrams. Okay, so trance lives on a continuum as a concept. The one end you have unconsciousness, the other end you have enlightenment. In the middle, and I've arranged these just as they came to mind, meditation, self-hypnosis, and flow are almost synonymous in terms of moving from the external to the internal. They're all different, but they're similar. Heterohypnosis, that's where there's one or more of us. Lucid dreaming is an interesting psychological phenomenon where you're dreaming, but you're aware that you're dreaming and you can direct your dreams. There are then, of course, the entheogens and the hallucinogens, which are getting a lot of airplay right now for everything from severe depression to other mental health issues. And they generate altered states of consciousness. To what degree they have a relationship to the other forms of trance, I personally don't know. But it's highly likely that once you've jump-started the process chemically, that the actual internal events are similar. Psychoses is included here because a lot of psychotics are in their own altered state of consciousness. They're in an odd form of trance. And if you look at the anthropological literature, the early shamans were in all likelihood considered to have some sort of psychosis, some sort of mental health issue. We could debate that at length, and I don't adhere to that concept, but it is in the literature. Okay. At this point, does anybody have a question? Everything makes sense? Absolutely clear?
I don't
We don't have
see-
any questions.
Okay, very good. Back to work then.
I actually have a question.
Oh,
Yeah, I wasn't sure who to send the questions to. I'd forgotten in the beginning, so I just wanted to ask. I know Kate Thompson was
Yes.
a dentist and
we'll
very.
get to Kay eventually.
You will, okay, because I didn't know whether there are videos available of her working or best works to read if you're not familiar with her work, and I don't know if you'll get to that later.
Well, I will, and there will be a book pictured on the screen. It is the collected works of Kay Thompson, written by Karen Olness and, oh God, I can't remember the second name. Kane, I think, Sarah Kane, or Sarah Lee Kane. But yes, you can find the entire works of Kay. There are some videos of her getting dermabrasion done. And in many of the conferences she attended where they were recorded, you may be able to get your hands on some recordings.
Right, I didn't know whether ASCH had any of the recordings available.
That I can't speak to because I don't know what's in the library.
Okay.
Though I'm sure somebody from ASCH will be happy and willing to find out for you.
Thank you.
You're welcome. Okay, so let's define hypnosis. I don't know how many of you have read the APA Division 30 definition of hypnosis, or the regression in service of the ego, and there are dozens of definitions of hypnosis. But to the average wet-fingered amalgam smith, they're useless. Absolutely without meaning. So the one that my buddy Reginald Humphreys came up with many years ago with Kathleen Egan, it's physiological. Any state of marked dominance of either branch of the autonomic nervous system constitutes a trance. Now, for those of us that forgot our anatomy, there's a very quick description. We have the sympathetic nervous system and the parasympathetic nervous system, and needless to say, they do different things. Different neurochemicals involved, and the vagus nerve, which now is very popular, the polyvagal theory of stuff, is the parasympathetic half. So if they're in balance as they ought to be, the parasympathetic tone is just a slight bit more than the sympathetic nervous system tone, which is out of balance in this image. So Reg, being the kind of guy he was, created this chart. And the parasympathetic trance states are sleep, meditation, hypnosis, anything that tends to be healing, rejuvenating. The sympathetic trances, panic states, acute pain, psychoses, they're all toxic. And of course, this is a continuum. And when my phobic patient comes in and stands at the end of my operatory screaming at me after days of being in pain, I would guess that the patient's in a sympathetic trance state. So my object and job is to take them from that state to at least a neutral state so that at least we can communicate. Because when you are in one of those fight or flight trance states, you're in blinders, it's blind panic, and you're looking for things in the environment that are going to kill you. And everything is going to be interpreted negatively. So you have to have a neutral state, and if you can manage it in the same appointment, a parasympathetic state, so that you can communicate with the patient. So what are the signs of hypnosis? One of the best books I ever read, and I still go back to it quite frequently, Dave Ellman's Hypnotherapy, first published in 1964. Crown House Publishing has the rights now, but I'm sure you can get the copies off Amazon for a reasonable price. If you look at these signs of hypnosis, these physical signs that he, as a stage hypnotist that trained dentists and physicians, observed, they're all parasympathetically oriented, and the eyeballs rolling upwards is Bell's phenomenon. And it's the basis of the hypnotic induction profile, any number of the rapid inductions. And it happens automatically through the parasympathetic nervous system, so why not utilize it? So this definition that Reginald came up with Kathleen is wonderful in my humble opinion, in that it is universally useful, from the microcosm to the macrocosm. And so as a dentist, we see this every day when that patient is sitting in our chair. Now, Etzel Cardania suggests that a hypnotic state is actually a combination of states. And there's been a lot of discussion about that over the years. And I endorse that concept, because you can never hold a very specific state for too long, because the monkey mind, the conscious mind, always gets in the way. But if you know that, you can at least work with it. Now, Erickson had the concept of utilization. Read the signs that the patient or the client brings in, figure out which half of the autonomic nervous system is in overdrive, and then deal with it. Create rapport, induce, either formally or informally, and then move on with a positive session. Okay, any questions? Somebody, anybody? Everything making sense so far?
No questions in the chat.
Okay, moving on then. For dentists, and probably physicians as well, but when our sales reps come in and say, hey, I got the latest gadget, you just can't live without it, your patients need it, da-da-da-da-da. I'll give you a perfect example. The chemomechanical caries reduction system to eliminate the drill way back about 30 years ago, barely made it to the market and then died out because we just weren't seeing that kind of decay anymore. You look at the trend that halitosis brought us. Everybody was getting meters to measure volatile gases from the mouth to diagnose the degree to which fetor oris was lurking in your patient's oral cavity, and then selling them something to deal with it. That too has gone by the wayside. So that had to be validated. There was a lot of good marketing, some science behind it. So what's the validation for hypnosis and hypnodontics? About 2002, this book came to the marketplace and gave me anxiety like you wouldn't believe. It was a think tank that went out there and decided for the Fortune 500 companies what the marketplace was going to look like and what was driving it. And this underlined sentence, which basically states that consciousness-based technologies are what's going to be the driver for the marketplace in the future. And they talked about Uber brands, where all sorts of things fall under one brand. Welcome to Amazon and eBay. They talked about the degree to which consciousness stealing and directing things would take over. Well, that's what's driving the marketplace. Perhaps we as dentists ought to know what's in the marketplace and figure out how to utilize it. Now, Charles Tart, for those of you that have been around a while, or those of you that are interested in altered states of consciousness, like Ellman's book on hypnosis, in my opinion, is a seminal book. This is a seminal book on altered states, in spite of the fact that it's written in 1971. Back then, he said, altered states were going to become increasingly important in modern life, which was then echoed all those years later by the think tank. And as mentioned earlier from Cardania, or rather Michael Murphy, those areas that and cultures where they're valued, they're really utilized on a consistent basis. Now, the other part of validation, all of life, even with enlightened altruism, is based on this basic concept. And the photograph of the lady there is Ayn Rand, who is actually a nice Russian immigrant to the United States and came up with objectivist philosophy. And we all ask the question, what's in it for me? So let's look at the patient's perspective on that. For those that aren't phobic, it's a great relaxation. self-control, psychologically and physiologically, particularly after 2 years of being locked down and afraid to go outside. Some sort of ability to control both our minds and our bodies, not a bad concept. Anxiety management. For the dental folk, time distortion is invaluable. Acute pain management, chronic pain management. They're different. And if you want really good information on those, I recommend Mark Jensen's work and Dave Patterson's work, especially on chronic pain. Habit management. Now, the one I've been trying to disengage from is picking up my cell phone every 30 seconds to see what's going on in the world. I'm sure there's a hypnotic application that I can do that. However, the next perspective that's crucially important in a dental context is your staff. If you're having a bad day looking for that mid-buccal canal, your assistant's having an even worse day. So personal stress management is a biggie. Personal goal achievement. We teach it to patients. Why shouldn't the staff avail themselves? And for the staff, patients are like wild cats. They need herding. Well, if you've got a patient who's being taught hypnosis, or more specifically, self-hypnosis, since our mantra is all hypnosis is self-hypnosis clinically, they're easier to manage because they're not going to be having anxiety attacks as they come into the office. It's also time saving. It could be used as a lost leader, a little time invested up front, and then subsequent appointments just flow easily and smoothly. Now, as the urban legend says, we dentists have the highest suicide rate known to man. It's not true. It's actually no worse than any other frontline first responder, but the basis of that is stress. Well, in the last 3 years, and with the geopolitical situation today, you need something to manage your stress. Personal goal achievement. Again, why not avail yourself? If you've got better stress management, personal stress management, you've got better goal accomplishment, that in no uncertain terms will enhance staff relations. Certainly, it's going to be noticeable to the staff that you're a little different, and it's going to enhance patient management. Any questions, comments, observations? Going once, going twice, thrice? Okay, moving on. Let's talk about phenomena and applications. In hypnosis, we elicit, induce, generate, anticipate a whole bunch of phenomena. Idiomotor phenomena. These are those micro muscular movements. And before we started, Dave Work and I were discussing last night's hypnotic induction or a hypnotic idea exchange workshop where implicit rapport generation was being talked about and paying attention to the micro-physical movements or gross movements of your patient. Well, for us dentists, it's second nature. But the problem is we don't know what it means and we don't necessarily know what to do with it. Well, if you understand hypnosis, you have an insight into what all of those signals are telling you. And what I've listed there on the left are the usual sorts of idiomotor phenomena that we utilize anywhere from ratifying a trance to inducing the trance and garnering information from the patient. Inhibition of stuff. On the surface of it, it looks like stage magic. Automatic movements happen because we inhibit the patient's control of them, if you will. Arms levitate, stuff like that there. Fingers can be locked together. Eyelid catalepsy is phenomenally easy to do. I have a favorite induction, which was created by John Hartland, or at least used by him, which involves arm catalepsy to induce a very quick trance. These are both induction methods and can be used to ratify the trance. Why do we talk about trance ratification? Those of us that have had some experience in hypnosis know that a lot of our patients will say in a formal session, but doc, I didn't feel like I was hypnotized. The fact that their analog or their physiologic signs that I'm reading to me tell me that everything I wanted happened, but their conscious minds didn't quite get the drift, that it was happening, they just didn't think so. So we have to come up with really subtle methods to ratify that trance did occur for the conscious mind. So the patient walks out, A, happy, B, eager to practice and follow whatever homework that's being assigned. Because if they don't think anything's happened, then why would they come back for it? Idiosensory is a little more involved, using all of our sensorium. And it's the same sort of things. And the other nice feature about it is you can take a particular, we'll call it a symptom for lack of anything else, and you can change it. You can reframe it, as we like to say, so that it's not the same creature afterwards. And if it's an image from a childhood dental experience where the mean, nasty dentist was there with all those torture devices, that can be restructured so that it has no emotion, or it's totally changed in the patient's mind, and their senses aren't going to be aware of anything like that in the future. Dissociation is got a lot of definitions. I'm a simple man, so I like the fact that it means I'm not me. That is, my conscious mind isn't involved. It's gone off someplace. And the best example of that, for all you Star Trek fans out there, the original series, where the virus invaded the starship into the computer system, and to give it something to do, Spock asked it to calculate pi to the last digit. Being a transcendental number, it's an infinite number. You can't calculate at this moment in time the last digit of pi. It's impossible. So the virus, or rather the computer, was busy. They had time to eradicate the virus from the ship. Well, that's what we're doing in hypnosis with the conscious mind. And one of the best and easiest things is a safe room, or a happy place, to quote Dabney Ewan. It's an opportunity to escape from the situation and go someplace happy. We can generate analgesia and anesthesia. And dentists, going back to the early days, when dentists resurrected the interest in clinical hypnosis, this is one of those things. It's crucial to our well-being. It's crucial to our abilities to function. I've had patients that are allergic to chemical anesthetics, both local and general. And I've had patients where you're in the middle of a series of extractions and the anesthetic fails, especially if they're redheads. There is a genetic variation in the redhead, which makes them far more insensitive to chemical anesthesia and far more anxious. And then anxiety itself can override the chemical anesthesia. So it's a vicious circle. So we can use it au naturel, or we can use it in combination. Hypnotic dreams. We can use that to rehearse dental procedures. Post-hypnotic suggestion, well, that's like bread and butter in dental hypnosis. You can change behaviors. You can use it as a reinduction cue. And you can help them practice with a post-hypnotic suggestion. And of course, the more they practice, it's like riding a bike. Though I must admit, there has been debate over the years about, can you improve and enhance dental hypnosis or hypnotic skills? Some research says yes, some say no. But one of the things that I've always noted, you may be the worst hypnotic subject based on suggestibility testing or hypnotizability testing. And yet, if you have a need, it's going to work. Hyperamnesia, age regression, all of these can be used to change past experiences to the degree that they may not be in the province of dentists everywhere in the world. That's something you would have to be familiar with in your own jurisdiction, but it is a very useful phenomenon. Amnesia, in the early days of hypnosis, the argument about hypnosis was that it wasn't real hypnosis if there wasn't a spontaneous amnesia for the experience. Now, whether that's the case today, I don't recall. I don't even know if anybody really discusses that anymore. But amnesia for the dental experience is ideal. Why remember something traumatic if you don't have to? It's like the day I got married. I still don't remember what happened. I do seem to recall signing on a dotted line. That was about it. So amnesia has its value. Now, the classic trance phenomenon is a sense of involuntariness. You're asking the patient to imagine that a hand is getting lighter and lighter because there are a bouquet of helium-filled balloons attached to the wrist. And as it floats up, lo and behold, when you ask the patient, it will feel like that arm did that on its own. That is the classic suggestion effect. That is perhaps, in my humble opinion again, the most germane indicator of hypnosis. And it's a wonderful trance ratifier. Okay, any questions so far?
I don't see any in the chat box.
Okay, moving on. Considerations. Now, what could this be? And why that set of faces? Well, before we go tinkering about with hypnosis in people's heads, we ought to know about people's heads. Now, if your dental training was anything like mine 44 years ago, we had virtually no psychology in dentistry. What little we had wouldn't even fill a thimble. And yet, if we're going to do this and use a psychological instrument, and I'll put that in quotation marks because we could debate that at some length, it behooves us to understand something about mental health issues, and in my case, fearful patients, the dental folk, and what's actually going on in their world and what it is that we engender. Now, these are all in my library that you see posted here on the screen. And the Brits, and the top left book there, the Psychiatric Disorders in Dental Practice, is a very slender little book, packed with information, comes out of Britain. And to this day, I have no idea why the Brits have as much on the psychology of dentistry, unless it may be put down to the national healthcare system and the offshoot of the socialized dental experience, perhaps. At any rate, if you're going to do this, you got to have some insight. Now, just to go back for a moment, I also spent part-time 16 years working at a tertiary care mental health hospital here in Hamilton, alongside my private practice. So I've seen every form of psychopathology known to man. And I've seen dental stuff that you don't see in the textbooks because they don't sit still long enough to be photographed. So take it from me. If you're going to tinker in the head, you have to know something about where you're tinkering. Now let's look at oral facial manifestations of psychiatric disease. All of these diseases I've listed there have an underlying anxiety component. If you're depressed, you live in the past. If you're anxious, you live in the future, you're never in the moment. temporomandibular joint disorders, pain, chronic pain, with an unknown future. Of course, you're going to be anxious. Who wouldn't be? The question is, does it hinder your ability to function? Bruxism, grinding and clenching. For those of you that may be sitting in and aren't dentists, once you've heard that enamel wearing on enamel, you will never forget it. Tension headaches, recurrent aphthous ulcers, the bane of stressed out people. They're microscopic and hurt 1,000-fold their size. Now, for those of us that have lasers, we are very happy to laser them and make them go away. And they're very easy to do that way. But for those that don't have lasers, all of the other approaches and techniques that are used tend to use caustic chemicals or other drugs, and it's not steroids, that kind of thing. And it's annoying. And lichen planus is another one of those autoimmune diseases which is rampant with anxiety, and we see it in the mouth. Underlying adjustment disorder. Anybody ever have a burning mouth syndrome patient? These folks are hard to contend with. There are 3 known variants, if memory serves. They do tend to be brought on by some kind of stressor. And there's depression involved, anxiety for sure. And it's just a lousy way to go through life. And since the mouth is so crucial to our existence, we dentists should be able to at least offer some help. If we look at phobic states, which odontophobia is the bulk of the patients that I see, it's not just a simple phobia in the sense that it has subcategories: dentures, cancers, AIDS, body dysmorphic fears. And somebody with a denture is the ultimate dental cripple. It's like losing your leg or your arm. And being phobic of that or dealing with those phobias, they can be managed with hypnosis quite nicely. But do you know what you're managing? So definitely look into stuff. Now, here we have two columns. On the left, we have an excerpt from what was ultimately the Seattle group's definition of the 4 types of dental fear, phobia, and anxieties. On the right-hand side is their best equivalent in DSM categorization and the ICD categories. Unfortunately, when they came up with these categories for the dentist, they really didn't find appropriate non-dental world descriptors, because sometimes you have to communicate with a physician or a psychiatrist, psychologist, and you have to be able to describe, hopefully in understandable terms, mutually understandable terms, what your patient is suffering. So that's there. Now, psychotic states. When I worked at the hospital, I knew, based on my patients, if they were having a dental problem, they were becoming more psychotic and their meds weren't working, or vice versa. So if you have a known mental health patient and they're beginning to behave oddly, they may indeed be in some psychotic state. Phantom bite, I mean, for all of us that adjust occlusion, you can't cure that easily. A lot of my patients at the hospital used to swear that they're in the amalgam in the upper second molar was a transceiver installed by the CIA to listen to their thoughts. So, you know, somebody walks in with one of those, you've got a psychotic state on your hands. Any questions so far? Make sense to everybody?
Nothing in chat.
Okay, moving on. Let's talk about applications. So what I've done here is I went back to the luminaries of our profession, and somewhat historically as well. And I've teased out the essences of their treatment modalities. So this gentleman is my buddy, Victor Rausch. And I have to say that in my entire hypnosis career, 3 people have impacted me dramatically. Victor, my brother from the other mother, Ashley Goodman, and Dabney Ewan. Victor's claim to fame is in the mid-70s, and we'll be more about this later. He had a cholecystectomy with nothing but self-hypnosis. Pretty impressive feat. His basic premise when working with patients, maintain eye contact. Now, for those of you folks that know about the hypnotic gaze, the look into my eyes, in the first or second issue of ASCH's journal, the American Journal of Clinical Hypnosis, Erickson writes about that. You can access that online. It's worth the read. Touch. We dentists have permission to touch, as my professor said above the clavicle, mind you, but we have permission to touch. Anchoring things with a shoulder touch, grounding a patient with a shoulder touch, using a finger touching a forehead as an induction technique. Again, we have touch. Touch works wonders because hypnosis uses the entire sensorium. And to do that, touch is priceless. Self-protection. We'll talk about that later some more, but that's crucial. Anchoring, you want them to walk out of there feeling good, that they've accomplished something. Even if they're not in a formal trance, look into their eyes, catch their subconscious, and give them the message. These were his basic principles, and these are principles I use today, and I recommend that you examine what you're doing, and if you're missing something, add it into the mix. Let's talk about odontophobia. Now, the gentleman you see there, Lou Dugan, God rest him, was an oral surgeon, a psychologist, and a forensic dentist. And when Lou passed away, that's when I got parachuted in to not only do my board exam, but to teach a workshop, an introductory workshop with my buddy Ashley, who was then grading me as he was the VP of the board at the time and still is. Lou was an interesting character and had a not unlike Victor Rausch. They're about the same height, 5'5", 5'6" maybe, but they could fill a room with their presence. They were charismatic, or are charismatic. Now, because he was a psychologist, he could explore for traumatic experiences and such like, and do an age regression. It's not in all our bailiwicks, and it may not be something we're comfortable doing anyway. Neurolinguistic programming talks about this as collapsing of anchors, which is something simple that we could do without necessarily the exploration for the source of the problem. You can use hypnosis as a substitute or as a supplement for pre-medication. So if they're going to take a sedative, a Valium, or whatever is your drug of choice, they can take an awful lot less. A lot of good studies were done in Scandinavia with full-blown general anesthesia patients, some 1,500 or so, if memory serves, and both morbidity, the mortality diminished, and the amount of anesthetic used was halved. And I think for our patients' lungs and livers, that's not a bad thing. Pain management. Well, not only should we manage it if we inflict it. Now, in Victor's world, if you have an acute case and the patient is in absolute distress, you want to use an authoritarian style of hypnosis, direct instructions, commands, if you will. They're already in that sympathetic nervous system trance state. So you want their attention and you want them to follow your instructions immediately. And there's the phrase he used to use a lot. You can read that for yourselves while I ramble on. Now, if your patient is not in distress, it's not an acute moment, then you would be more permissive, maternal or Ericksonian, if you will. Finger pressure to induce anesthesia is very good, as we discussed earlier in the hypnotic phenomena. And if you ever get a chance to see Victor's video, he's doing a set of immediate dentures. He extracts 6 upper front teeth with only hypnoanesthesia, inserts the denture into the patient's mouth, and then has a nice chat, and the patient is absolutely comfortable in using the dentures. Now, he did this for a colleague. This is interesting. Stuff is being written all over the screen. That's kind of cute. I don't quite know what it means, but could be a fly on my screen, perhaps. Anyway, you certainly want to, what's going on here now? You certainly want to use hypnosis with denture adaptation. And you can do it in a form of hypnosis known as walking or waking hypnosis, which goes back to the 40s. And you don't actually have a formal trance, but you do have enough. That's intriguing. You do have enough of a altered state that by choosing your words carefully, you can accomplish a great many things. People that have problems with dentures usually exhibit any one of these signs and symptoms there for you. And you always want to have positive suggestions where possible. Now, other techniques for working up to this, especially if you have gaggers, have them practice with a spoon or a plastic disc on a piece of floss that they can quickly pull out of their mouths if they have to. And then, of course, increasing the time. Trial denture bases are also a possibility. But all of this works better if the wheels are greased with hypnosis. Also, ego strengthening, which is something Hartland was famous for. And this is from Barsby in a little monograph called Hypnosis and Dentistry, published in Europe. Ego strengthening is crucial, especially if you're dealing with somebody who is now a dental cripple. You would ego strengthen regardless with just about every patient you hypnotize, but you would certainly go out of your way for somebody like a denture patient. Let me tell you a story about a patient of mine, a young man. He was a real estate agent, shows up at my office, and he's totally macho. He's going to go sit in my chair. We're going to do the initial exam, the complete oral examination, but he has to go to the bathroom. Okay. Next thing I know, I hear this thud in the hallway. He had fainted, left a dent in the concrete floor. So we put him in the chair. First thing we did was hypnosis. We didn't do the exam. We worked on giving him some psychological and physiologic control, because fainting is not a good thing in a dental office. And many folks, Frost is one of the early dentists, the early psychosomatic dentists. He suggested hypnosis as the means of engendering relaxation to prevent fainting. Well, the premise there is that you're addressing the parasympathetic nervous system again. Now, Eli and Kleinhaus have a couple of very good books and a lot of articles. Injections are really up there for causing faints. And again, hypnosis, relaxation, parasympathetic trance enhancement. The habit. Schechter was one of those early dentists with Erickson and a third gentleman who I keep forgetting his name, were the first to do the road shows out and about the States, promulgating clinical hypnosis for ASCH. And they have a textbook from those early workshops, which is hard to find, but is still available out there. And you can read what they talk about. Now, tongue thrusts in dentistry lead to a whole bunch of issues, everything from anterior open bites to just socially unacceptable behavior, and for which you use the ability to hallucinate in hypnosis to generate positive or negative images. You associate the tongue thrust with a negative scene and feelings, which you then correct. And then, like the collapsing of anchors, in theory, it should mitigate the problem. Same sort of thing with thumb sucking. Now, in one of Erickson's collection of volumes written with Rossi, he talks about the child being convinced to give all 10 fingers equal time in the mouth, and to the point where you create a schedule, which 2 fingers with which other 2 fingers are in the mouth at the same time. The idea is that the child is going to be frustrated and give up. What's interesting, though, I think Erickson got this from Garland Frost, again, one of the very early hypnodontists who also wrote a dental hypnosis book. In our business, the joint is a major problem. 10% of the population have symptoms. Probably 5% of that 10% actually need treatment. It can be mild from a clicking sound to downright pain and an inability to function and chew and carry on. It has a whole bunch of causes, and you can see them listed there. But what I want you to focus on is the sleep disorder, sleep apnea. And you're talking to a guy who sleeps with his vacuum cleaner on his nose every night to survive. One of the interesting features about bruxers is that we can't diagnose, is it stress related, psychological, which is the stress, or other issues, structural, as in the bite relationship. And there's a whole lot of debate about how occlusion impacts the joint. And depending on which school you belong to, the orthodontist or the prosthodontist, or even the periodontist, you'll have a different perspective on that. Now, one of the common items in all of the treatments recommended was when you become aware, you wake up, realize that you were grinding, and then go back to sleep. Now, if you're sleep apneic, you're doing that innumerable times an hour anyway. So my hearty recommendation is, before you do any suggestions like that, do an Epworth sleep scale on your patient to rule out apnea. And if they are apneic, then consider the kind of suggestions you would be offering. I think it's critical to their health and well-being. Now, Eli and Summer in that little monograph on dental hypnosis talk about psychodynamic techniques. Again, it's a jurisdictional question whether the average dentist in their office has this fall into their scope of practice. But if it does, then there are many ways of finding an underlying cause if it isn't physiological like apnea. Now, Harold Golden, God bless him, was an oral surgeon. And one of his statements that he used, which is germane regardless of the cause, nothing is important enough in life to eat myself up. That becomes the self-suggestion, the mantra every night before you drop off to sleep. And then, since you can all have access to this later, I won't bore you with the content of the slide. But that one thing in a meditative process that Harold used to have, where every morning he would look into the mirror, glance at his reflection, and then smile at all of his body parts. This is a technique that I've seen come out of the Far East in meditative techniques, but it's a very nice way to offer a little gentleness to yourself. So I recommend that. Nieberger, put your tongue between your teeth upon becoming aware of this, and then you don't want to do this. Now, I am really curious as to why somebody feels compelled to draw on the screen, because these graffiti that I see on my screen are certainly not emanating from me. So I would recommend that you cease and desist, if you would, please. At any rate, Erickson, again, here talks about replacing bruxing with nocturnal gum chewing as a habit, which will probably end very quickly, not unlike the thumb sucking habit. Dov Glazer, who's still active as far as I know down in New Orleans, of course, temporomandibular disorders and headaches of all sorts go hand in hand, and he addresses that again with the creation of relaxation and concepts of calmness and tranquility. Lou Dubin's approach was a little more academic, which may work with engineers, and I've had a few of those folks as patients who actually want to sit down and diagram out the whole mechanism. But I'm not sure it would work as well with a lot of today's patients that I happen to see. Now, if you want current good information, up-to-date research, our Danish colleague Randy Abramson is at the fore. And I've listed here 5 of her current publications, and they're ongoing at the present. So I recommend you look her up online and access all of these. They're quite interesting. Now, motivation. We want to motivate people to do things. And oral hygiene is one of them. I'm not personally convinced that it's going to happen, because I think the world is divided genetically into those who floss and those who don't. And as an aside, when I was in dental school, my profs in first year told us that that monkey there could cut a class 1 cavity prep. So you wonder where it left the rest of us in the class. At any rate, suggestions for oral health are critical, especially, I have a lady who comes to mind who has a rather odd connective tissue disorder, and it manifests hideously in her mouth. She's had a lot of heavy-duty restorative dentistry done. Her gums are fighting for dear life, as is the rest of her mouth. And so suggestions to her to maintain her health and her oral health particularly are crucial. And again, waking hypnosis is ideal for this. The gaggers. Now, if my buddy Ashley were actually presenting with me, he makes a wonderful gagging sound. Gagging, you want to control. But now, before we even address gagging in the way of controlling it, gagging is a reflex that's trying to prevent us from inhaling unpleasant things. But it may also be related to a traumatic experience. And this is again going back to our lack of psychological education in dentistry. You may have a trauma victim, a rape survivor, or a drowning victim. Well, if they were a drowning victim, they'd be dead. A near drowning victim. Let me try and speak English. Before you go gung-ho into trying to fix the gag, it might be nice to know why the gag is there. And gags can be physiologic or psychologic, and the further anterior they are in the mouth, the greater likelihood is that they're psychogenic. Oh, sorry about that. Now, Hal Golden's approach with denture wear and gagging, he would talk about the body as the prized possession, and that you control the body and not the other way around. And then he would explain gagging and in an eyes open trance. And in dentistry, we can use eyes open trance a lot. He would put a needle through the back of the hand after he's got glove anesthesia. We don't do that anymore. It's not a good idea. However, there are ways that you can demonstrate the anesthesia without having to draw blood. Jay Henry, who was our president of the board, he's got an interesting approach where using imagery, you're breathing through the neck. And so that your breathing takes place lower down. And that if you're taking impressions on the patient or anything that's causing them to gag, it won't be impacting their ability to breathe. And of course, dentures are the most notorious gag-inducing things. Now, do we know where gagging is conditioned the most and by whom? To my knowledge, it is that physician with his tongue depressor. Starting from the earliest age, when they go in there looking at the back of the throat with that tongue depressor. Are we surprised then that when they come in for an impression with us, that suddenly breakfast is on the floor? At any rate, Lou Dubin for gagging would talk about holding your breath and how that's an impossibility. It's an offshoot of his temporal tap, where he would tap on a person's head and have a nice patter about what he's doing. None of it needs to be accurate. And then he has the linchpin phrase, which is, and this works with everybody if they belong to the human race. And to be honest, I've yet to have a failure when I do that. Now, let's talk about anesthesia. You can replace local. You can do hypnoanesthesia. If we believe the statistics, people fall onto a bell curve and only one end is going to be virtuoso enough to pull this off. Maybe yes, maybe no. If there's a need, it tends to work. You would use with direct suggestions, numbness, cold, glove anesthesia, playing with a snowball, that kind of thing. If you give the pain a color, that is, you ask the patient to give it a color, you can then change the color. You can morph it. You can talk about the gate control theory of pain and find the switch in their heads and have them flip the switch. There are any number of methods you can use for that. Now, at the other end, if you use nitrous oxide in dental school, This was my textbook, by the way. The interesting statement out of this textbook was, with the introduction of the word may, the role of suggestion enters the conscious sedative technique. Now, in the technique that we were taught, you would tell the patient that you may be aware of my voice is coming from a distance. You may notice tingling and buzzing around your lips. You may feel dissociated from your body. And the word may is constantly there as the interjection or the coupling word for whatever follows it, which, if you understand hypnosis, it's a hypnotic induction. What the nitrous oxide is doing is greasing the wheels. It's an anxiolytic. So that being the case, because if you think about it, our machines nowhere near capable of general anesthesia depth nitrous administration. And in the last half hour back in the day, I was taught you give them pure oxygen and the nitrous is out of the system within a couple of minutes. So it begs the question, if they're on pure oxygen and there's no more nitrous effect, then why are they still behaving as though they're inhaling the laughing gas? Because the anxiolytic with the conjunction of a hypnotic induction did the trick. And if you're too cheap to get yourself a full nitrous setup with scavengers and stuff, use the hypnosis, much cheaper. Same with IV. You can drop the amount necessary, and using hypnotic communication during the process is also a benefit. Same with general anesthesia. Decreased morbidity, decreased drug administration, and you're out of the hospital much sooner. And this was Schechter's opinion. Teach it, and anything will cause it. Which is interesting because Ellman used to say that once you got hypnosis, any suggestion thereafter deepened the hypnosis. So that if you are running a patter, a spiel while you're working with the patient, you are deepening their altered state of consciousness. And they will either go deeper just to escape listening to you, or it will actually register with them and accomplish what has to be done. Lou Dubin, anesthesia and alter the awareness of the pain, dissociation, increased tolerance. You can role play in preparation, and you would do this with further recall visits. William Kroger, one of the early textbooks on the subject of hypnosis. There's a description of using your finger to suggest numbness as you gently luxate the tooth. And then you determine the degree of anesthesia by poking with the Explorer, as we do anyway. Now, in our business, I like to describe it that we put on our hip waders, dress up in our rubber gloves, and go to work, because the oral cavity is usually awash with fluids. They can be blood or they can be saliva. For both of them, you can more or less use the same sort of imagery. Turn off the faucet, the lake emptied and dried up, as did the river or the stream. You're not eating, so there's no need for saliva. There are any number of suggestions. And I think that only creativity is the limitation for what kind of metaphor you might want to apply. When it comes to extractions and the control of blood, I'll give you an example of hemorrhagic control. When I was starting out in the business, I had a 6'5" 300-pound dental phobic engineer in my chair in a state of hypnosis while we were doing a root canal on his lower first molar. The tooth was so badly decayed that the landmarks were gone, and I created a swimming pool through the furcation of the root. Well, of course, this bled. So I said to the patient, let the blood rise to the crest of the alveolus and turn it off like a tap. Much to my amazement, within a few seconds, we had a clot. I finished the root canal, temporized the tooth, and we had it for another year. Now, what does an engineer know about an alveolar crest? Yet it is possible to offer suggestions to contain the hemorrhage and the saliva. And there are in the dentistry, in terms of hypnosis, research and publications is very sparse up until about the last decade or so. What you do have is dozens and dozens of case studies. And in the early journals, Hal Golan has several, I think Lou Dubin has several, working with hemophiliacs. So it's worth looking them up, both as a reference as to what is possible and for ideas on what sort of suggestions should be utilized or can be utilized. Okay, any questions so far? Well, since I don't see any questions or hear any questions, let's move on to techniques.
Gabor,
Yes.
we have a question from Dove, who's in the
Oh,
audience.
okay,
Um,
ask away.
You mentioned Bernie Mouse syndrome. What hypnotic suggestions would you offer the suffering patient?
Well, I remember having one patient who we did complete medical workups on her, and ultimately we determined it to be psychogenic in origin because none of the other physiologic indicators were present. So for her, the suggestions would be, if you have a burning sensation, you've got an inflammation, so coolness, a transferred glove anesthesia, certainly relaxation to mitigate the stress response. We want to engender that parasympathetic nervous system response and have that carried through the day, every day. Now, in this particular lady's case, her husband had died and she was recently widowed, and that was the initiating factor. Well, let me rephrase it. That was the sensitizing factor. She then had some dentistry, which turned it into a full initiated burning mouth situation. So you would address the symptoms. You may address the underlying cause. And certainly if it's burning, you want to put out the fire. So I would work on cool, calm, and comfortable. I hope that sufficiently answers the question. Anyway, moving on. Before you is the humble saliva ejector. I call it a spit stick, but that's just me. Why is it here? I give the saliva ejector to every one of my patients to hold in their mouths. Some are very successful. Some are unsuccessful, and the thing is actually hovering outside the mouth. But the moment I give most of my patients this saliva ejector, I find the following to take place. A, their mouths stay open, almost cataleptically, without my having to ask them to keep opening. Secondly, they dissociate from the experience because somehow their focus is the saliva ejector and the task they've been given. Thirdly, especially for those folks where these things are hovering and not actually in the oral cavity, they're not bothered by whatever liquids may pool in the back before the assistant can get at it with the high volume suction. So even without doing anything formal, I have found over the years that saliva ejector is crucial. And when I use my laser, where we're doing hard tissue dentistry with a laser, there's limited room in there, so rubber dams and rubber dam clamps and things like that preclude the ability to get in there. This works wonderfully. So the next time you're in the operatory with your patient, give them a saliva ejector and observe what happens. And then play off that saliva ejector and see how it proceeds. So let's talk about the techniques that are out there. Now, this is the way I've described inductions. There's the passive, sort of conventional or classical, where the patient looks to be asleep, usually related to some sort of authoritarian induction, also referred to as paternal or direct. There's the passive alert, which Dave Work, if you're still with us, is your form of alert hypnosis, where you're seated or standing or whatever, but you're alert but not physically active. And then there's the active alert, a la the stationary bike that Eva Banyai in Hilgard's lab back in the day started using. In dentistry, we usually want the patient to be passive in the chair for safety, if no other reason. They can be passively alert in a hypnotic state, which may work to our benefit depending on the intervention that we're doing. And then, of course, there's the post-hypnotic suggestion. Now, in an acute case, as we've already mentioned, you'd want to use the authoritarian approach. In a non-acute or non-emergent situation, you'd be permissive, maternal, or indirect. If I understand correctly, the term paternal and maternal goes back to a Hungarian psychologist named Fodor, if memory serves, but I am getting a bit senile as I get older. Now, there are covert inductions. These are done quickly to do something. Also could be considered waking hypnosis. And the reason I mention this is that there's no informed consent. You do not sit down and have a full formal process. You do it on the fly as you're treating the patient. What I used to do with kids, particularly when I wanted to get the local into their mouths, I would have them use the dreaming arm, which was a format I got from Erickson. They hold the arm up. They have a dream. Today, that could be a TV or a streaming video, whatever is the most appropriate imagery and metaphor for the child in the chair. While they're engaged, you give them the local and you're done. And then they can put their hand down. Overt inductions, that is a formal full half-hour, hour-long session. You would have a formal intake. You would get your informed consent. And you may do it over several sessions, depending on what it is you're dealing with. So these are the two poles of the way we would work in dentistry and possibly other hands-on professions. Now, the conventional techniques tend to be relaxation-based and take a long time. The rapid induction analgesia that Barber came up with takes 20 minutes. None of us dentists have 20 minutes of overhead that we can spare to do an induction. So there are lots of rapid inductions, and you can find them and access them all over the place. And if you want to read a very good article, Lance Rucker in the American Journal of Clinical Hypnosis about 3 years ago, wrote a wonderful article on dental hypnosis, outlining these very concepts of the place we work. So let's talk about hypnosis, the marketplace, and how to integrate it into your practice. There's no point in being a hypnodontist if you don't know how to make it work Monday morning, which was what the original title of this presentation was meant to be, Monday morning stuff. When I first started doing presentations some, I don't know, 20 years ago, I put this together. This was what was in the marketplace at the time that had some relationship to an altered state of consciousness and hypnosis. Today, there's probably a lot more, but this more or less is probably still germane to the discussion. Now, why is it interesting to understand what's in the marketplace? This is a book by a psychologist, Kevin Hogan. It's now out in its second edition. This was the first edition. Hypnosis is communicating with someone or some group's mind. Remember back to Crabtree's group mind trance. The receiver of the message is using significantly less critical thought. And they're not going to evaluate the message in the same way as they would otherwise. That's going to happen in your office. That's going to happen whether you're consciously aware of it, just talking to one of these phobic, frightened people. So it behooves us to understand all of hypnosis and how it integrates into our society and our practices. Now, this quote comes from an article where communication systems are being utilized by everybody and everything. They want us to act without reflection. Think about Twitter feeds. Think about all the other social media feeds out there and the responses they engender. And some of them demonstrate absolutely no critical thought. Created their own pictures of the world, which they're now feeding into us and are trying to structure our inner lives, which goes back to those earlier comments, both from Tart's book in the early 70s to the New Culture of Desire in 2002. And rest assured that the world is dominated by consciousness altering screens everywhere we look. And if you're like me, it's welded to your hand. And then you have guys like Joe Vitale, used to hang out at the National Guild of Hypnotists with these books. If we thought we were the keepers of hypnosis, we're wrong. I had a colleague who took an NLP course and then was describing how he had a great time moving patients up and down and doing his bidding, basically. We have to be aware, both for ourselves, our staff, and our patients. This ran in our local newspaper a few years back, and it was a pretty good article on the benefits of hypnosis. Except what did they do? They got a stock picture, which blew the content of the story to pieces. This showed up on my newspaper one morning, stuck to it on a sticky note, where Positive Changes Hypnosis was offering 50% off. And just about every larger metropolitan setting has or had a Positive Changes Hypnosis storefront, if you will. And then, the internet, well, what can I say? I'm sure you've all spelunked in the internet. Let's talk about practice management. Who, with whom, where, when, and how. Let's think about business for a moment. All businesses have what's known as a unique selling proposition or a unique selling feature. They're one and the same thing. Some dentists used to cater to cowards. That was their watchword. It was posted up in the office. It was on stickers. It was balloons, whatever. Some, their unique selling features, they hand out a free whitening kit with every exam that they do. Others use lasers. Some use hypnosis. Now, my buddy Albrecht Schmier, the founder and father of the German Dental Hypnosis Society, was describing that when Germany took dentistry partially off the socialized medicine scheme and demanded a co-payment of 10 Deutschmarks at the time, this was before the euro, there was a village that had 4 dentists. Only one was an original member of the society. Within a short time after that, all 4 were members, trying to use hypnosis as a unique selling proposition. That unique selling proposition has to be communicated somehow. Now, this book was put out in 1997. And to make a long story short, it comes down to these 4 questions at the bottom, or statements, if you will. Your patient walks in. I know you. It's that whole Cheers thing. You go to where everybody knows your name. You tell me what you want. Patient has a chief complaint, a desire, whiter, brighter teeth, or they want to look 20 again. I make it. I deliver it. And then I remember this for next time. Well, that next time is your continuing care, recall, or supportive care system, which is now generally automated in most dental practices in North America. Your intake questions, I know you. Yes, there's a name, there's some demographic information, insurance information, an oral exam. I know you, but do you really know you? Have you created sufficient rapport that you truly understand what the patient wants so that you can deliver it? We're all doing this every day in the office. And using therapeutic communication might just be the oil that makes it work better. Now, once you've got this firmly rooted in your mind and you have a unique selling feature, how do you integrate this into your practice? And this is different than the usual workshop training where you're taught what applications you might use it for. This is how do you physically get it to work Monday morning? So over the years, I've discovered in my travels several models. One where there's the doctor and he does it only. The doctor relegates it to the hygienist once the patient is conditioned. There are audio tapes. Well, tapes for those of us from a certain generation today, they'd be MP4 files. Or you can have a consultant on staff. In the doctor-only model, you have to consider it's labor intensive and it's dollar limiting because you have to tie up a room that might otherwise generate an awful lot more return than the hypnosis session. Now, you could use it as a lost leader. You're going to lose some money up front, conditioning the patient, and then everything else moves smoothly and the dentistry pays for itself. That is true and does work, but it is also predicated on what the patient needs, how long they're going to be returning patients, and whether the patient is willing to buy into the process. When the doctor is the one doing this, you also eliminate any jurisdictional scope of practice concerns. Now, if you relegate it to the hygienist, in my world, I've conditioned the patient. The hygienist is informed enough to know the patient is in an altered state and doesn't blunder into something, lets the patient get on with it, or if necessary, helps the patient a wee bit. It has a better return on your investment. It's less of a lost leader. And as in all other forms of dentistry, it is a form of leveraging time. The tapes, for lack of a better word, very nice. And for those do-it-yourself patients who are a little distrustful, but don't mind spending the money on a prepared tape, very nice. They put it on their ear, they put their earbuds on and they play away while you work. And you tell them that the only time they have to pay attention to you is when you talk to them directly. You can say that anyway, which gives the patient the excuse to have a fugue from the situation which they're in. And it's relatively inexpensive. Now, if you have to do more hypnosis and the dentistry, then you might charge for the hypnosis extra. Now, Albrecht in his practice always had a psychologist on staff. And that was great. Because a lot more service in that fifth model, the whole wellness concept of a practice was being realized. Now, I like brief therapy. I usually do 2 half-hour sessions a week apart with homework assigned during the week. And then we do the dentistry on the 3rd week, again with practice. The first session is to understand how hypnosis feels and the usual formal intake stuff. The second session is dealing with the particular issues of the patient. And what I liked about Victor Rausch's commentary to me years ago was you work with the whole patient. You're not necessarily hung up on a particular aspect of a problem. I had a patient recently come to me for hypnosis, and she had chronic pain. In the very first session, my usual pattern includes nothing disturbs, nothing concerns, and nothing bothers. Now that phrase goes back to the beginning of dental hypnosis, some 60 or 70 years ago. Not particularly unique or creative on my part. However, she came back to me a week later and said, it was great. I was feeling much better. So you're working holistically rather than necessarily symptomatically. Anyway, so that's the way I tend to do things. Now, how do you select your patient? If you propose it, you have the patient of record. There is already a rapport that exists between you, and you're offering a very specific solution to a specific problem. And by then, it should go easily. Now, if it's a new patient or the patient requests, William Wester, whose photograph you see there, and Clinical Hypnosis, if memory serves, was a 2-volume set. I only have the first volume, sadly. Very good book. These were the questions that he would ask or have a patient fill out in part of the intake process so that you have information. And if you've ever read Dabney Ewan's book, he also has an interesting questionnaire that he has the patients fill out. And I also have them fill that out in writing. In the day and age of the digital world, I like people to do that with pen and paper. We scan it in, but I think the very act of neuromuscularly writing stuff out and mulling over it before you put it to paper has a benefit beyond check boxes on a computer screen. But I could be wrong. And then these are questions we also get in writing. How did they hear about us? What do they know about hypnosis? Why did they choose it? And more importantly, did they choose it or is somebody else telling them to use it? And what are they expecting from this? And have they ever been hypnotized before? Because then all you have to do for an induction is remember when the last time you were in hypnosis. Remember how that felt. So do what you have to do to go there now. And your work's done for you. So I would still have a patient of record fill all of this stuff out anyway, because it gives us more food for thought and more opportunity to create patient-specific metaphors and suggestions. And of course, you have to figure out how you're going to pay for all of this because there's an overhead. And in dentistry, you need a room, a chaperone, or one of your auxiliaries. And the only way that really works well is if you have your hygienist or a whole slew of hygienists working away madly, and maybe even an associate in other rooms to subsidize the cost of what you're doing. I don't know how many of you have ever thought about that, but it's certainly good food for thought. Insurance in our world today, everybody's insurance driven, whether it's multiple companies like in the States or single payers in healthcare in Canada. In dentistry, thank God, we still have multiple insurance companies, but patients are insurance driven. And some might pay, most don't. So it's an out-of-pocket expense for the patient. So they really do have to be motivated. When are you going to schedule this? What time of day? Now, I understand Mark Jensen was actually saying that in the morning, it seems about 11 o'clock in the morning is one of the best times to do hypnosis. Could be. I like to do it at that time because it can flow into my lunch hour if I run long and there's no pressure of having to see the next patient. Or at the end of the day, works well for me as well. You have to figure out the length of your session. I like a half an hour that tends to drag a little because you can tell I'm loquacious. And then you want to figure out where the sessions are going to take place. I do them all in my private office, and then we only do it when we're doing the treatment with it in the operatory, because the operatory is the torture chamber everybody wants to avoid. And then, of course, you have to wonder about your chaperone's availability. And then you have some questions to answer. Will it be formal or informal? The ethical questions that come out of informal on-the-fly hypnosis, you're going to have to answer for yourselves, because there is no informed consent if you do it that way. But then again, as I've heard described, since there is no formal definition, then you're just giving them suggestions. You're just talking to them. What they do with them is up to them. But you have to consider the ethics for yourselves. And I hope you do spend some time thinking about it. And then everybody in the office has to be trained. I'll give you an example. I run health and safety services at a Scout leadership training camp in New York State. And one morning at 5, the camp cook dislocated his shoulder. Well, I couldn't put his shoulder back into his socket. So I put him in the car. I used Elman's rapid induction for pain relief. We drove 30 miles on backcountry roads, and he was perfectly fine until the physician on call looked at him and goes, "Oh, that must really hurt." And the trance was over. So it's crucial that everybody in your office know what you're doing and not blunder into something. If auxiliaries are using it, there's the scope of practice question, training, certification, experience, the awareness that they have of what's happening, their role as a chaperone. And of course, they have to be able to market this when patient, because every patient I've ever encountered, I'll explain something in as simple language as I can. I'll leave the room and then they'll ask the assistant what I just said. Or they'll go to the front desk and ask, do they really need what I just recommended? So not only are they to be aware of what's going on so they don't cause a problem, but they also should be able to market this because they are your patient liaisons most of the time. So how are you going to get the word out? Well, we just mentioned the staff. They should have 1-minute scripts, as Jennifer de St. George used to talk about years ago in her practice management seminars. They're basically 1-minute suggestions about real and imagined people and experiences and concerns. Promotional materials, well, today most of it takes place online, but some of the old school stuff is still important. And word of mouth today is this. I mean, I cannot identify half of these or even a quarter of these icons as to what social media they relate to. But this is what happens in the world today. External marketing, other dentists, dental specialists, physicians, psychologists, other allied healthcare practitioners. You might even want to drop something in the media or put it on the internet. one of the things that I like, and I have a small cadre of psychologists that are both patients and referral sources. I don't know too many psychiatrists in my neighborhood because they're rare as hen's teeth in the way our socialized medicine is set up in Ontario. Social workers are good. And then if you're lucky, you could have them actually work in your office, or you refer the patient to their office before you do anything with them. So while I wet my whistle, any questions?
We have several. Let me start. Let's see. David Vu asked, are you allowing the patient to hold the saliva ejector in their mouth or outside the mouth?
I give it to the patient, and if it floats out of the mouth, I gently push it back into the mouth, but the patient's holding the saliva ejector.
Okay. Farial Shamsi asked, are there any hands-on courses for dentists that teach how to do hypnosis for patients?
It's called the American Society of Clinical Hypnosis. For one. For two, if you ever get a chance to hang out with the German Dental Hypnosis Society, I highly recommend it. The Brits, the British Medical and Dental Society have regular courses. Some of them are online. And then if you come to like the ASCH annual meeting, where again this year I have the pleasure and privilege of presenting this very subject, but because we're in person, we get to actually play and do inductions and stuff like that there. So there are some places. It's just a matter of doing a little digging and sending an email to ASCH Central and having them give you the information. And then again, what you will find is all of us dental hypnotist types, you ask us a question, we can't shut up. So feel free.
Okay. Tusa asked, do you always have a chaperone? And then what if we have a security camera in the room, or what if they bring someone with them?
All of the above is fine.
Okay. That covers.
Okay.
Let's see. Hold on. We got another one. Izat says, what suggestion to gagging? What suggestion to gagging at night?
Gagging at night, as in when they're trying to brush their teeth?
I don't know. Izat, if you can turn your microphone on, you can talk. I think.
Yeah, totally. Thank you so much for this opportunity. Well, I have this hard time to go to bed after eating certain kind of food.
Mhm.
And I gag at night, and that did not happen till age of 13 or 14, perhaps, after a dramatic trauma. It was an earthquake.
Okay.
And because of it, till today, I'm still experiencing that at night. So do you have any suggestions?
Okay, now my suggestion is that I don't think you're going to deal with the gagging until you deal with the trauma.
Okay.
So I would suggest you find somebody in the mental health world that you know and trust, and work through the trauma with them. I think that's your best bet, because it sounds like you're stuck in a video loop, if you will, a recurrent video loop. Every time you try and brush your teeth, it reifies the trauma experienced during the earthquake and the existential threat that it represented. So I think you really have to deal with that rather than just try and deal with the symptomology.
And
this is, to quote Harold Golan years ago when I was preparing for my board exams, because most dentists are not qualified to deal with psychological issues in depth, we have to work around things physiologically. So yes, you could do things like a glove anesthesia that's transferred to the oral cavity, so nothing is feeling, because it's like having your hands become insensate playing with a snowball or carrying a block of ice. You don't feel anything. You could transfer that kind of sensation to the mouth. And you could, as a post-hypnotic reinduction cue, every time you put the toothpaste on the toothbrush and move towards the oral cavity, everything immediately becomes frozen. That would be the physiologic workaround. But I think for the best long-term solution, you might want to deal with the trauma itself.
And is that something you have experienced or came across in your practice?
I have run into folks with trauma, and lots of it. And generally at that point, I use what a colleague of mine calls tincture of referral. I refer to one of my mental health professionals to deal with the underlying issues for a whole lot of reasons. Jurisdictionally, it's out of my bailiwick. Secondly, even if I were competent and confident that I could help, I don't think I'd have enough time and the patient enough money to make it happen. And lastly, if I want my gallbladder out, I'll go to the general surgeon rather than asking the dentist to do it. So if there's an underlying trauma that you obviously are aware of as the etiological factor, then deal with that through the appropriate professional. That would be my recommendation.
Excellent. Thank you so much.
You're welcome. Anything else before we move on? All righty then.
Yeah, we are at the time.
Oh.
Time.
Okay, well, let me.
And there's a couple other comments, but no more big questions. So.
Okay, well, let me just fly through this. And I do mean fly so that everybody can get to bed. Trance and communication, big deal for dentists, okay? This study was done by the Canadian Dental Association. Basically speaking, less than 10% of Canadians trust their dentists or think they get value. And what did they want from dentists? Being good communicators. Well, then knowing how to communicate therapeutically is important. Compassion is a big issue too. This is one of my favorite quotes from the play Tea House of the August Moon. Pain makes man think, thought makes man wise, wisdom makes life endurable. And it's that wisdom that helps with compassion. And the reason compassion is important, and the British have coined this term, the heart sink patient, which means you see their name, your heart sinks. These people are going to challenge your compassion. And sooner or later, you're going to have compassion fatigue. It's a form of burnout, but I think it's more insidious because it's a form of burnout that lets you continue functioning. You're dysthymic in a sense. And you're not really dealing with the issue. You're just going through the motions. And that's poor service to yourself, to your patients, and to everybody around you. So the methodology for dealing with it, based on the research, includes meditation and self-hypnosis, which goes back to the benefits of this for the dentist. And we won't waste more time on that. Hypnosis, why do clinicians use hypnosis? Other therapeutic results were inadequate. It's more holistic. Patients request it. 45% are familiar with it to some degree. 38% have some familiarity, but not much. My friend Eva Banyai has the social psychobiological model that talks about mutual attunement, which is another way of phrasing rapport. And when you're doing that in an intimate relationship like hypnosis, it maintains both organisms, if you will. Now, very quickly, the German dental hypnosis did some great research just recently. It's just recently been published, and there now exists as the pinnacle of evolution, Homo hypnoticus dentalis. We are the crowning glory of evolution. They chose their member dentists and non-member dentists, put them through a stack of questionnaires, finding out what their personality styles were. I've listed them here. The ones in bold are actually DSM and ICD terms. And what did they find? We are intuitive and schizotypal at heart. All hypnodontists seem to fit into this category. So that is an interesting little tidbit. Now, I don't want to spend a lot of time on trance abuse, but let me fly through this because I want you to think about this. This book by Dennis Weir is a good place to start about trance abuse. Here's my little tree diagram. Forget the other agencies. Forget all that stuff because we've talked about it somewhat. You can be abusive, as that anecdote about this colleague of mine. It can be intentional. It can be unintentional. It can also be an abuse by the subject. And I don't have time to get into a particular individual that comes to mind from my practice experiences. But think about the abuse of trance. Weir contends that embedded commands do not induce trance, but are forms of abuse. They use a disabled cognition to gain acceptance of either your bad ideas and suggestions or your good ideas and suggestions. Eldon Taylor, who used to work for the FBI, technology is out there getting us to be thoughtless. And if we think we're in a light trance, there's no question we are, if you're watching the tube or playing with the internet. So, and then again, we've already mentioned that the marketplace is out there busy trying to get even with us. And now to give due course to I think the most important part of this exercise. This is an interesting book I recommend for those that are really intrigued by strange things. But the alchemist's operations with all his stuff is not to transmute base metal into gold, but basically to transmute themselves. Hypnodontists do this. Now, my buddy Victor had his gallbladder out in the early 70s with nothing but self-hypnosis. He got off the table, walked back to the room, and was out of the hospital within a week. And back then, they flayed you like a fish. Now, I've got what he wrote for me down here, and you can get a hold of the handout or watch the video again and read all of this carefully. He describes his adventures in 78. And since then, he's done an awful lot more self-surgeries that have been videotaped. And at the end of the day, it changed his life and his perception of hypnosis forever. Hypnosis, self-hypnosis, for you as well as your patient, is a life skill. It transmutes you and gives you the opportunity to become Homo hypnoticus dentalis. And everybody that I've asked says essentially the same thing. My other brother there with Dabney, if you read through all of it, he gets to the same point. It's a benefit to him, a benefit to the patients, and it's a phenomenal communication tool. And then Albrecht, the organization he formed, back when he formed it, over the years are about 5,000 dental hypnotists. Their membership is still going strong. They're very active and they all use rapid hypnosis. He also created CDs and what have you, as we discussed. This lady from Germany again will echo exactly the same thing. The dentist's individual and professional development. It is the alchemical transmutation that takes place. First, by volitionally using stuff and then intentionally. Kay Thompson, I knew the lady, she was phenomenal. I've never known anybody who could use language like her. It makes dentistry more tolerable for the frightened patient so they can handle it with comfort, dignity, and control. It's spontaneous in the dental chair. Lord knows we see it every day. For the lady that asked, that's the book, The Art of Therapeutic Communication, by Karen Olness and Sarah Lee Kane. I like her phrase, I am not what I was, nor am I what I will be, but I am becoming satisfied with the moment and the movement. That is a restatement of the chemical transmutation. Now, this gentleman, and I really do have to mention this man, that's one of my favorite books in hypnosis. It's in my library. It's hard to come by. He published it out of his own pocket. It's known as a vanity publication. He contends that hypnotic suggestion is the greatest power in the universe. He wrote this book at a day and age when there was a lot of dental interest in hypnosis. Marcello Romai is in Uruguay who is single-handedly trying to generate an organization in dental hypnosis. And his commentary is, we put our attention, our energy flows. The more you attend to improving yourself through hypnotic suggestion, the more your energy flows. My buddy Mike Gow in Scotland, phenomenal dentist, phenomenal hypnotist. Again, he echoes the same things. Not only is it great for communications, but it is life-changing for the patients, but it's also life-changing for the dentist. And he's doing a movie on the life and times of James Braid, and he likes to dress up like James Braid. It comes to the same ultimate conclusions. Now, this was on the beach in Malta, the last night of the conference in Gozo with the German Dental Hypnosis Society. That is the shaman Joseph Johns reaching into the fire, removing embers and passing them out. And I'm standing on the far right in those white pants. This is the power of trance. This is the power of hypnosis. This is the power of dental hypnosis. Ladies and gentlemen, I thank you for listening. And being a typical dentist, I ran over time, so forgive me. Mea culpa. Any
Thank you
final
so much,
questions?
Gabor, for a very thoughtful and informative presentation. The session was recorded and will be available soon on the ASCH website. Tomorrow, you will receive links to a program evaluation and Gabor's resource document. Completion of the evaluation is required to obtain your CEs. We hope you take a few minutes to give us your feedback. It helps ensure we're offering program content that makes a difference to you in your practice. And by the way, the 2023 ASCH annual meeting and scientific workshops will be in Jacksonville, March 3rd through 6th, and go to the ASCH website for details. So thank you for coming and being with us tonight. Hope that everybody has a great holiday season. Be well. Take care. Bye-bye.
Bye-bye. Thank you. Thank you very much. Thank you.
You're welcome.
That's a great presentation.
You're welcome.
Thank you. Thank you, everybody.
Thank you. That was real nice.
You're welcome. I'm glad you found it interesting.
Gabor, if we could just hang on for a little bit
Sure.
after folks go, just do a quick debrief.
Sure, I'm easy.
We were able to figure out how to get the red marks off the screen.
Great, thank you. I wondered what that was.
Well, when you're sharing the screen, one of the settings can be that people can share the drawing tool. And
Oh,
evidently
okay.
somebody was doing that, but there was also a tool for deleting the whole thing. So that's what,
okay.
I found that and we got that off. And then for future reference, Joanna will make sure that setting is not enabled that allows that sort of sharing of the drawing. So
Well,
we've got what, one more to Stephen.
that was a learning experience for me. I've never seen that drawing.
I've never seen it. Joanna said she'd never seen it.
Yeah, I've never seen anybody do that. Yikes.
At least they weren't drawing
Yeah.
rude things. They were just scribbling.
Exactly.
Yeah, I seem to think it was related to this one person who kept popping in and out.
Yeah, I finally, I was holding off on letting him in. And I'll be curious to see the information tomorrow. I have a hunch it's someone who was just giving out the link.
Yeah, I communicated with him and he said that he had, that it wasn't clear whether somebody had gotten the link from it. I said, well, how many people would you give the link to? And he apologized and said, evidently he passed the link out. So
Yeah, well, he didn't respond to me, so I have to respond to you.
yeah,
I'll probably just remember everybody.
he was certainly, that name certainly popped up a lot.
Oh,
Yeah.
Well, Gabor, I think you did a great job. I found it very
presentation.
interesting. And any feedback to us?
No, I actually the once I got the information on what the emergency number should be and who was actually doing what, life was fine.
Okay. Well, thank you so much.
Oh, you're welcome.
Really appreciate it, speaking for the rest of the committee. And thanks, Joanna.
Mhm.
Fine job.
Absolutely.
And am I correct, though? The people will get links tomorrow?
Yes, for that, for the evaluation, yep. And like I said, we'll go ahead and we'll just, I've got a little bit of editing that needs to be done on the video. And